A 38-year-old man presents to the outpatient department with low-grade fever, night sweats, and weight loss for the past 6 months. He reports generalized fatigue and occasional shortness of breath on exertion. 2 weeks ago, he noticed painful nodules on his fingers, but he thought they were insect bites. He also complains of new left-sided flank pain radiating to the groin, which developed suddenly yesterday. He denies cough, hemoptysis, or chest pain. What is your differential diagnosis for this patient? And how would you manage this patient? Hello, my name is Benjamin and welcome to Med One Pager. And in this video, I'm going to be talking about infective endocarditis. And at the end of this video, I will be going back to our case vignette and I'll be looking at it, explaining the diagnosis, and then how you would go about the management of such a patient. So infective endocarditis is an infection of the endocardial surface of the heart, and normally this is the surface that is lining the inner surface of the heart. So what happens is that if we have a discontinuity in that endocardial lining, if we have an injury to or a damage to that endocardial lining, and it so happens that we also have a bacteremia going on within the blood of within the patient, there are chances that we are going to develop infective endocarditis. And how it's going to happen is that these different risk factors that we have, maybe we have a prosthetic, maybe we have an immunosuppressed individual, maybe we have a history of rheumatic heart disease, maybe you have a congenital heart disease, and most of these ones are going to cause a situation whereby we have maybe a turbulent flow that is constantly hitting a certain point of the endocardial lining of the heart. And this is going to cause endocardial damage. And when we have endocardial damage, platelets are going to attach themselves to that endocardium or that endothelial lining that is exposed, and as well as fibrin. And this is going to form a thrombus. And this is going to be what we call a sterile thrombus, because it's not going to have any organisms within it. But if it so happens that we have a certain bacteria around that has the virulence or the ability to attach to that thrombus, it's going to colonize that thrombus and it will multiply and form a biofilm, and it will cause actually a bigger and bigger thrombus, and it will be now termed as a septic thrombus. So when we have a big thrombus, a couple of things a good number of things can happen actually. And one of them is obstruction. If it's very big, it is very able to obstruct the lumen of maybe a valve or a place where blood is supposed to pass. And if it does not cause an obstruction, there's a chance that if it is next to a valve, it may cause distortion of that valve. Because it's an extra weight it's pulling on that valve, it may cause a distortion. It may cause perforation of the cap or the cusp of that valve, and it may cause a rupture of the chordae tendineae. And these are the fibers that are attached to the valve. So if it causes rupture of that chordae tendineae, it's going to disrupt the functioning of that valve. So if it is not affecting the valve itself, it may actually start to embolize, whereby that thrombus starts to break off small particles, and it can cause this septic emboli to go into different parts of the body, and they're going wherever they will settle, they'll be causing a lot of problems there. The emboli can just cut off the blood supply of a particular organ, maybe the spleen, maybe a brain, maybe a kidney. And when it causes this, if it causes an infection in the brain, you're going to see someone presenting with features of a stroke. If it's the spleen, they could have a splenomegaly. If it is the kidney, they may have acute pain. They may have a lot of problems going on with their renal function. Then besides that, the gross amount of or the large amount of organisms in the blood is going to cause an immune reaction, and the immune reaction is going to involve production of antibodies, and these antibodies are going to attach to antigens, and we shall have antigen-antibody complexes. And if these complexes are deposited in small blood vessels, wherever they go, they're going to cause when they're trapped in small blood vessels, they're going to actually cause an inflammatory response there, and we shall have a vasculitis, a small vessel vasculitis, and this is going to be seen in various organs in the eyes. It can be seen in the palms, in the soles of the feet. And when we have this vasculitis, we may actually have an end ischemia happening in that area. We have an ischemia occurring in that area of that small vessel because of this, and that is going to be painful. And most of the time when it happens in the fingers, we have development of those nodules that are called the Osler nodes. And these are very, very painful. But when we have actually a septic emboli just going somewhere and it's just a septic emboli, it will always be seen as these kind of lesions in the hand, but they are actually painless. They are painless. Yeah. So when we go to the clinical features or the clinical presentation of someone with infective endocarditis and or infective endocarditis, is going to come in two ways. That sometimes it's going to be an acute and severe disease, or we may have actually a subacute disease or a subacute infective endocarditis, which may actually not be having the typical picture that you may think about. The patient is going to have it for a long while, and they're going to be struggling with sickness. So when we have a subacute setting, mostly see the patient who has had maybe an existing heart disease already for a long time, and then probably the organism comes in later and they start to develop this kind of sickness that evolves slowly with somehow subtle features, but they're going to have these features of a long period of having infective endocarditis, which called the peripheral stigmata of infective endocarditis. So in general, they're going to have fever, they're going to have chills, they're going to have night sweats, they're going to have weight loss, and this is going to resemble the B symptoms that we see in mostly tuberculosis and lymphoma. And in the comment section, you could tell me actually some other diseases that present with the B symptoms. So apart from that, since the pathology is originating in the heart, it is actually important to look at how it's going to affect the heart. And one of the most common things is that they're going to present with heart failure because of the destruction of the valve or destruction of that valve, yes. So if we have maybe the quadrant tendinae holding the mitral valve rupturing, we are going to have a mitral regurgitation, and that mitral regurgitation will present as heart failure, and it can happen for other valves. So the most affected valves are the tricuspid and the aortic valves of the heart. Then we can also get conduction defects, especially if you have abscesses forming, because this organism can actually just cause an abscess there, and this abscess is going to interfere with the conduction of electricity and of the heart, and then we shall have a heart block. Then we go to the peripheral stigmata of infective endocarditis, and these ones are going to appear as either vascular phenomena or they're going to appear as immunologic phenomena. So vascular phenomena are going to come as a result of these small emboli that come from the thrombus that is lodged in the heart. So one of them is going to be splinter hemorrhages. We're going to have the Janeway lesions. We're going to have conjunctival petachia, and we're going to have arterial emboli and mycotic aneurysms. And typically, these are going to be most of the time painless. Then when we go to the immunologic phenomena, these are caused by the deposition of these antigen-antibody complexes, and these are going to cause a vasculitis wherever they will dislodge in those small vessels. And if they occur in the hands or the toes, it's going to be the Osler nodes. And if they occur in the retina, they are going to be called the rot spots. And if they actually be deposited in the basement membrane of the kidney, we're going to have a glomerulonephritis. Then we have the complications, because someone can actually just coming with complications of infective endocarditis, and these include valve destruction, heart failure, abscess, arrhythmias. We can have strokes occurring, splenic infarct, pulmonary emboli, and actually sometimes you have immune-mediated glomerulonephritis happening, gastrulitis, and we can have also a persistent sepsis, because this emboli is actually impenetrable to the white blood cells in the heart. So it is kind of protected by that fabric coating and everything. So it's going to continue to give off those organisms into blood, and it's going to cause a persistent sepsis. So when you look at the microbiology, The organism can be approached in very different ways. We can look at the organisms that affect the native valves and those that affect the prosthetic valves. And the native valves are going to be mostly affected by Streptococcus viridans. And this is a normal flora in the mouth. And most of the time it's going to come from dental procedures. Someone has had a dental procedure, and this organism finds its way into the bloodstream. Then we can have Staph aureus, mostly in the IV drug users, and Staph aureus is mostly going to cause a very, very aggressive disease, and it will have an acute presentation. Then we have the enterococci. Then we have prosthetic valve. When we have a prosthetic valve, the most common organism is the Staphylococcus epididymis, mostly in the first 60 days. And then Staph aureus and some gram-negative bacilli, as well as fungi. But afterwards, when it goes beyond 60 days, I think the organism that cause infective endocarditis are going to be similar to the ones that cause infective endocarditis in the native valves. Then in IV drug users, when they have infective endocarditis, it's going to be mostly caused by Staph aureus because it's a normal flora in the skin, and as they're injecting themselves, they're going to introduce it in the bloodstream, and it's going to also affect the tricuspid valve mostly, because the blood from the peripheral is going to enter into the blood and meet the tricuspid valve before it is actually taken to the lungs, which has a more complex immune system. Yeah, so we have some other organisms like Staph galacticus, and this is mostly associated with people who have abdominal malignancy. So if you did culture and found this organism, it is important that you rule out abdominal malignancy in this patient. Then we have others like Enterococcus faecium and fecalis, and these ones are common in the elderly, mostly after instrumentation of the GI, genitourinary, and the gastrointestinal systems. We have Coxiella burnetii, which is Q fever found when we have animal contact. We have brucella, we have yeast and fungi. Then we have the hazard group of bacteria are actually gram-negative bacteria that are normal flora in the oral cavity, and these ones are going to give us an infective endocarditis. When we do the cultures, most of the time they're not going to show up because they are gram-negative. So when we're diagnosing infective endocarditis, we use the Duke's criteria, and it has the major and the minor criteria. So the major criteria talks about having a positive blood culture, as well as having the evidence of endocardial involvement. What we mean by a positive blood culture is either one, you do a blood culture, and when you do this blood culture, you find typical organisms. And these are the Streptococcus viridans, Staphylococcus bovis, the Hasek organisms, the Staphylococcus aureus or Enterococci. And we have to make sure there's no other primary focus of the primary focus of these organisms. We don't have maybe an abscess going on somewhere, such and such. Then if it is not that, we have to have persistently positive blood culture. So when someone comes in and you suspect that they have infective endocarditis, most of the time you're going to take multiple sets of cultures, and the set of cultures consists of 2 tubes, one for aerobic and one for anaerobic. Then after taking those cultures, you can start the antibiotics. But if someone is unstable, then you may need to do all the cultures within 1 hour's time, and then you begin the antibiotics. And so if you have 2 cultures that are taken more than 12 hours apart, and they are persistently having these organisms, they have organisms in them, then we shall say maybe this is infective endocarditis. Or if you have all of the 3 cultures taken, or majority of the cultures taken that are 1 hour apart that are 1 hour apart, then we can say we have a positive blood culture. We have met one of the major criteria. Then when we do echocardiography and you see a vegetation, or you see an abscess, or you see a new partial dehiscency attached to a prosthetic valve on our echocardiography, you know that we have evidence of endocardial involvement. And in most cases, the transesophageal echocardiogram is going to be more sensitive than the transthoracic echocardiography. Then if you have a new valvular regurgitation, then we have the minor criteria whereby we have predisposition, maybe we have a heart condition, that may be leading to infective endocarditis, like if you have rheumatic heart fever, a rheumatic heart disease, you have congenital, you have a prosthetic valve, a congenital anomaly, an intravenous drug use, or that is a predisposition, and that is one of the minor criteria. If you have a fever greater than 38 degrees Celsius, if you have vascular phenomena like major arterial emboli, you have septic pulmonary infarct, you have mycotic aneurysms, you have intracranial hemorrhage, you have conjunctival hemorrhage and Janeway lesions, that is under the vascular phenomena. If you have immune phenomena, for example, glomerulonephritis, you're having Osler nose growth spots or a positive rheumatoid factor. And yes, I know you're going to ask yourself, how is a positive rheumatoid factor coming in? But I would like to hear what you think about that in the comment section, and I will be also trying to give an answer in the comment section. Then you have microbiological evidence, where we have positive blood culture, but our culture that we have does not meet the major criteria. So for us to diagnose, you either have to have two. So you can have two major criteria, or one major plus 3 minor or 5 minor. And that is a definitive diagnosis of infective endocarditis. And if we don't have that, we can't. If we have one major and one minor or 3 minor, we can say we have the possibility of having infective endocarditis. Then when you go to the investigations, you need to do the blood cultures, transthoracic, so echocardiography. We can do the transthoracic. You have to do labs. Sometimes you have an elevated ESR or CRP. You have normocytic anemia. You have a microscopic hematuria, and you can do imaging or MRI to look for these emboli if embolic complications are suspected. Then when you go to the management, the general principles of management is that we're going to give prolonged IV doses of antibiotics. We are going to tailor the therapy to the culture. We're going to first begin with empiric antibiotics. Then we try to tailor according to the culture and sensitivity. And when that fails, we can go to the surgical interventions. So in antibiotics, we have, when you have a native valve, we are going to mostly begin with ampicillin, chlorpromazine, and gentamicin. This is what WHO mostly recommends. Then we have the prosthetic valve, where we can give vancomycin, cefepime. Then we go to the definitive therapy. If you have a very dense streptococci, that is penicillin sensitive, you can give penicillin G, or ceftriaxone plus or minus gentamicin. We can look at cloxacillin for Staph aureus, or nafcillin plus gentamicin. Then we can give vancomycin for MRSA, and so on. So to do the surgery or the surgical management, if we have heart failure from a valvular dysfunction and this valve is now it's regurgitating and we need replacement, we can do valve replacement. If we have an uncontrolled infection like an abscess, and if an abscess is not easy to penetrate with antibiotics, we may actually need to go and remove it surgically. If we want to prevent emboli and we have large vegetations of better than 10 millimeters, with some embolic events already happening, if we can do that, we can cut away the emboli. Then prevention, we mostly do prevention for high-risk patients. That is at least according to the American Heart Association. And this is in patients, for example, who have prosthetic valves, who have had the infective endocarditis previously. So when we are going to do dental procedures, or before we do these dental procedures, you're going to give 2 grams of amoxicillin orally 30 to 60 minutes before the procedure. Or if they're allergic, you can actually give clindamycin. So let us revisit our patient who had a fever, weight loss, Osler nodes, Janeway lesions, microscopic hematuria. So this patient, an examination, he was found to have a murmur, he was found to have a splenomegaly, and on further examination or further history, it was found out that he had had a dental extraction recently. So when you look at that, he has very, very many features of the criteria that he was fulfilling. So a diagnosis of infective endocarditis was made, and the management was continued. Cultures were withdrawn, and he was started on empiric antibiotics. Yeah. So thank you very much. If you found this video helpful, I would encourage you to subscribe to the channel or if you liked it, you can also do subscribe to the channel, and you can leave a comment, you can leave a like, and you can tell me what you think I should try in my next video. You can leave a topic, or you can also tell me if you would like to have more of these case vignettes coming in at the beginning and at the end of our videos. Thank you.